Hey, my name is Luke Klein, and today I'm going to be talking about lupus erythematosus. More specifically, I'm going to be talking about systemic lupus erythematosus. Now, you're probably wondering why there's a purple butterfly on the screen, and if you keep watching, it'll make a little bit more sense. So, names, just briefly. So, there are a lot of different names for lupus, a lot of different classifications. These are all names that I found in peer-reviewed published articles, and they're generally grouped under like system involvement. So you have cutaneous lupus erythematosus with skin involvement. Then you have all these little subclasses. You have neuropsychiatric systemic lupus erythematosus. You have kidney involvement with lupus nephritis. Then you have these sort of special cases. So neonatal lupus erythematosus is pretty interesting. Essentially, IgG crosses the placental barrier and interacts with the fetus in a pregnant mother. That causes widespread inflammation. So essentially, the IgG from the mother acts as an autoreactive antibody for the fetus, and so that causes lupus manifestation. You also have drug-induced lupus erythematosus. It's not entirely clear why that occurs, but it's temporary. So with lupus, you'll have these flares with periods of remission in between. And with drug-induced lupus erythematosus, there's no secondary or tertiary flare. It's just a single event. On to what is an autoimmune disease. So essentially, it's a loss of self-tolerance. With lupus, that results in autoantibody generation. You get this widespread inflammation. You can also have more localized inflammation. That's why you see cutaneous lupus erythematosus. But it's really a lot of inflammation caused by the self, by autoreactive antibodies. Now, as I mentioned previously, lupus is characterized by these flares, and that's not unique to lupus. A lot of other autoimmune disorders or diseases involve flares. So you have, rheumatoid arthritis, multiple sclerosis, psoriasis, and so on. A little bit of a historical perspective. So lupus was arguably first described in Greece by Hippocrates in 400 BC, but it wasn't until the 1800s that lupus was characterized, or lupus was classified officially in a way that matches modern-day criteria. I mentioned the 1900s in France because Urbanus of Tours looked at these discoid circular rashes caused by lupus and thought they looked like wolf bites, so wolf lupus. I don't really get it. And then the 1800s, as I mentioned before, descriptions of lupus really took off. And that was primarily due to the efforts of Cazenave and Kaposi. Kaposi really described this sort of malar butterfly rash because he thought it looked like a butterfly, and that's why there was a purple butterfly in the beginning. It's the sign of lupus awareness. You can see this graph under here, looking at the different countries where lupus is prevalent. You might notice that a few of these areas are completely white, and that's not necessarily because no one there has lupus. It's more so a limitation of the study. They didn't have data from those areas. So roughly 3.4 million people globally have lupus, and around 400 people are diagnosed with lupus each year. Of those people, 90% are women, likely due to hormonal influences, and African, American Indian, and Asian women are the most at risk. However, men that have lupus are more likely to get serious organ involvement. So risk factors, there isn't a clear cause of lupus, but there are a lot of different things that are associated with the severity and the occurrence of lupus. So looking at genetic factors, complement protein variants are seen in people with lupus. So generally you'll see C2, C4, and C1q variants. You also have HLA2 polymorphisms, more specifically HLA-DQA, DQB, and DR. And so those are really seen in people that have lupus and also that have anti-Rho or anti-SSB antibodies. You also have these hormonal risks or risk factors. So essentially, increased endogenous estrogen and decreased testosterone correlate positively with the onset and the severity of lupus. So individuals that are taking oral contraceptives, that are pregnant, or that have endometriosis are more at risk for developing lupus. On the other hand, menopause is associated with a decrease in lupus severity. And if you look at individuals over the age of 60 to 65, there isn't really a distinction between men and women getting lupus. There isn't that 9-to-1 probability. There are also environmental factors, and you really want to think of silica, stress, and cigarettes. Right here is a picture of someone with silicosis, which is caused by inhaling silica dust. Causes this scar tissue. And what's interesting thing is that silica can subvert self-tolerance checkpoints, so it can actually lead to the production of autoantibodies. Additionally, I don't have it written here, but the Epstein-Barr virus and actually COVID-19, so these sort of viral infections are positively correlated with the onset of lupus. Now, pathogenesis, as I mentioned previously, the cause isn't entirely clear, but this sort of pathway is pretty well mapped out. Essentially, what's going to happen is you have some sort of immune dysregulation that could be caused by one of these environmental factors, and that's going to cause, or it's going to correlate with an excess of apoptotic bodies and an inefficiency in clearing them out. So, you could have macrophages just aren't doing their job and performing phagocytosis to clear out those apoptotic cell components. That's going to result in persistent nuclear waste throughout the body, and antigen-presenting cells are likely to then interact with them through a pathogen-associated molecular pattern receptor. Antigen-presenting cells then going to present that to a T naught cell, so a naive T cell, a CD4 positive cell, and an increase in IL-4 and a decrease in IL-2 is really going to facilitate the differentiation into helper T2 cells, which is going to stimulate the humoral response. So Th2 cells are going to release an excessive amount of IL-10, and then B cells are also going to be more sensitive to IL-6. That's going to cause far more activation, differentiation, and proliferation of B cells. Additionally, there's a polarization for Th17 cells over Treg cells, which is going to affect anti-inflammatory mechanisms. This is then going to cause the production of autoantibodies, which is going to lead to inflammation through one of three ways. Either it's going to cause complement activation, immune complex deposition, or sometimes these autoantibodies, so if they're an anti-cardiolipin antibody, they can bind to cell surfaces and cause inflammation and the release of pro-inflammatory cytokines. So a lot of these signs and symptoms of lupus are not disease-specific. So you can have a low-grade fever and these more sort of constitutional symptoms. You also will have arthritis in many cases and pain during the flare-up. So if you have chronic pain or chronic fatigue or chronic arthritis, that's often not due to lupus itself, it's due to something else. And so that can kind of be ruled out when you're diagnosing lupus. You can also have hemolytic anemia and hypertension. Hypertension's a pretty serious concern in individuals that have lupus. Then you can also have these more system-specific signs and symptoms. So roughly 50% of individuals with systemic lupus erythematosus develop the malar rash. So you can see it here. A lot of them also develop these non-scarring rash, these discoid rashes, and in biopsies, interface dermatitis is often seen. With neuropsychiatric lupus erythematosus, central nervous system vasculitis and myelitis often causes like high fevers, seizures, strokes. Individuals may experience dizziness, delirium, psychosis, depression, anxiety. There's a lot of different symptoms that are associated with neuropsychiatric systemic lupus erythematosus. Additionally, it's not listed here, but with lupus nephritis, you often see hematuria, proteinuria, and increased risk of hypertension and lower limb edema. With diagnosis, as I mentioned previously, a lot of the signs and symptoms are not disease-specific, so it can be a little tricky when diagnosing lupus. Often, if someone is suspected of having lupus, a ANA or anti-nuclear antibody test will be ordered. However, like 7 to 15% of individuals that are healthy will test positive for this test. And if you look at individuals over the age of 65, that number jumps up to close to 30%. So generally, an ELISA will be used to test for super-specific anti-nuclear antibodies, such as like anti-Smith, anti-Rho, anti-SSB, anti-cardiolipin, these more specific antibodies that are associated with lupus. Additionally, you have a lot of clinical criteria. So as I mentioned previously, they could have delirium, psychosis, or seizure involved with neuropsychiatric lupus. They could have arthritis or ulcers, rashes. One of the more important things when looking at these criteria is that they have to fit within a certain time frame. So because lupus presents as flares, it won't be chronic. And so if someone complains of chronic pain, it likely isn't caused by lupus itself. However, it's interesting to note that 1/3 of individuals with lupus develop fibromyalgia, and so that's where that sort of chronic pain could come from. But at the same time, it has to last for a certain period of time. So if someone gets bit by a bug and they experience a rash that looks almost like the malar rash, or they have poison oak or poison ivy, ignoring the sort of circumstances, if that rash then disappears after a few days or a week, it likely isn't due to lupus. And so it's really a tricky thing to diagnose lupus, and you can look at all these criteria, but it's just very difficult to diagnose lupus. As far as treatment, there's no cure for lupus, so a lot of the medications are just aimed at minimizing the acute inflammation associated with flares. So for that purpose, you could have corticosteroids for that really acute inflammation, and then hydrochloroquine is used to reduce organ damage and reduce the risk of flares. However, with hydrochloroquine, it causes pretty severe retinal damage in some cases, and so people that are on it for a long period of time need to get semi-frequent eye checkups. Depending on how severe the lupus is, individuals may also be prescribed an immunosuppressant such as azathioprine, or a biologic like belimumab, which essentially reduces B-cell proliferation, or anifrolumab, which was pretty sure it was released pretty recently, and it's currently being approved for use in Europe. And that's going to inhibit IFN-IFNAR complex formation and downstream inflammatory cascades. Additionally, since cardiovascular disease is a pretty severe risk with individuals that have lupus, people are often prescribed ACE inhibitors or angiotensin II medications, angiotensin II receptor medications. Additionally, life behavioral changes are extremely important for individuals with lupus. So that can range from just avoiding these sort of flare triggers, not smoking, avoiding silica dust, things like that, to sleeping well, exercising, trying to minimize risk by minimize stress by meditating, getting vaccinated to ensure that you don't get an infection, a severe infection. And certain individuals will say that exercise is not people with lupus shouldn't exercise because they're already feeling fatigued, and exercise can place physical stress on individuals. However, most of the studies they looked at said that exercise is actually extraordinarily important for minimizing the risk of flare-ups, minimizing the severity of flare-ups, and leading to overall life benefits. As far as future outlook, research is still ongoing. As I mentioned previously, anifrolumab is currently being approved for use in Europe, so a lot of these medications are being rolled out and still be looked at, but it's likely that lupus will still be an issue 10 years from now. Thank you so much for watching. These are my sources, and I hope you have a great day.